Thank you. Thanks, Amal. Well, thank you all for being here. Can you all hear me okay in the back? I know it's a crowded room. I'll try to keep talking. If you can't hear me, just raise a hand, and I'll talk a little louder. It really is an honor to be a part of the Breakfast with the Experts. As Dr. Curry said, I've been to most of them, and my sense is the very best breakfasts with the experts are the ones that give the students a particular set of knowledge, skills, or attitudes, attributes that will prepare you better for the workforce. So what I'm going to talk about today is something that every one of you will be working on when you enter the health workforce, and that is this idea of population health. All right. I'm going to subtitle my talk, How High is the Wall in Your Town? And by the end of my presentation, hopefully you'll have an understanding of what population health is, why it's important, and why I chose this subtitle for the talk, How High is the Wall in Your Town? Let me start by saying that wherever you go in the United States, if you're going to be working in healthcare in the next 10 to 15 years, population health is going to be an inexorable part of your life. All right? You will be working with this idea of population health. It is part of the future of health and healthcare in America. So to talk about the future of healthcare in America, I want to go back in the past and start with a story about healthcare in another country some years ago, particularly 1982 and the country of Thailand in Southeast Asia. Okay? Particularly I want to talk about the Thai-Cambodian border. There's Thailand, there's Cambodia. Some of you will know that in the early 1970s there was a very long civil war in Cambodia, and towards the end of the 70s there was a large, rather significant genocide. A minimum of 1.3 million people and possibly as many as 3 million people were killed out of a population of 8 million. All right. Not unexpectedly, hundreds of thousands of them left the country as refugees, and there were a series of refugee camps formed along the Thai-Cambodian border in the late 70s and early 80s. Each of these camps was politically independent, associated with a different faction from Cambodia, and there was no communication and transmission between the two. The largest of the camps was Khao Dang Holding Center, which by 1982 had about 45,000 refugees, people waiting for resettlement to the developed world. It was reasonably well established by 82. There was a Japanese NGO that was providing surgical care, a French NGO that was providing internal medicine care, and an American NGO which was providing pediatric care. And these are some pictures from the pediatric ward in Khao Dang in 1982, and not surprisingly, it was for this purpose that I found myself in Khao Dang in 1982. Now, those of you that dress funny and look weird, there is hope for you for the future. All right? Going to Khao Dang in 1982 was a good experience for me in one sense because I got to see some diseases and conditions that are uncommon in the United States. But more for me, it was a reconnection with why I had gone into pediatrics in the first place. Okay, I had gotten, for those of you who know me won't be surprised to learn that I had gotten a little jaded with the high-tech nature of healthcare in the United States and had forgotten that really what we were doing was trying to improve the lives of children. Now, I don't tell you the story about Khao Dang in 1982 to talk about me. But of something that happened there about 5 weeks after I got there. I mentioned that there were a series of camps along the Thai-Cambodian border, and we were not allowed to have communication between the different camps. So we were somewhat surprised one day when a truck came down from one of the other camps, and in the truck was this child that was very, very sick, and within a couple of hours of arriving at our camp, that child had died. We didn't know what killed the child. We just sort of chalked it up to unfortunate experience. We were a pretty good NGO. We had good pediatricians. We had all sorts of healthcare options there, but we couldn't save that child. The next day, the truck came back from the same camp with another child who had died on the way. And in the next 11 days, I believe 8 kids were brought down from this other camp that were either dead or dying. Now, the problem was that we didn't know what these kids had. Okay, we weren't sure if it might have been some sort of advanced cerebral malaria, some sort of hemorrhagic encephalitis, whether it might have been an environmental exposure. Maybe they were exposed to a medication that was either tainted or was somehow inappropriate. The problem was we couldn't go to that other camp and figure out what was going on. Okay, we were stuck where we were. We could provide the best care possible for those kids when they arrived, but we couldn't go back to the other camp. Now, what does that have to do with providing health care in Tennessee in the next 10 to 15 years? Well, if you think about it, that story from Cambodia is a metaphor for the way we practice medicine in the States today. We are exquisitely well trained to provide care for people when they show up at the hospital, the clinic, the doctor's office. We're incredibly well trained to do that. But if you think about it, to really make a difference in the health of those people, we have to get back earlier in the system. Think about it. When someone shows up with lung cancer, no matter how good you are, you can have the best oncologic surgeon in the world, but they will tell you that the best time to intervene was first before that person ever started smoking, or second once they started to get them to quit. All right? Think about it. If someone shows up with diabetic retinopathy, losing their eyesight because of diabetes, you can have the best retinal surgeon in the world. But they will tell you that the best time to intervene was before the retinopathy developed from the diabetes, before the diabetes developed from the obesity, and before the obesity developed at all. If you have a motor vehicle accident, you can have the best trauma service in the world, but everyone will tell you the time to intervene was before that kid decided to drink and get behind the wheel of that car. All right? Time and time again, we are, as a profession, healthcare is exquisitely well trained to take care of the patient when they show up. But if you really want to improve the health of a population, you've got to be able to get back earlier in time to a camp before they show up where you are. All right? And that's the concept behind population health. Now, this isn't new, right? There's nothing new or earth-shattering about this. We've talked about health promotion, disease prevention for years. We talk about community health. We talk about prevention. We talk about preventive medicine. More generally, we call this stuff public health, right? And for people on the outside, they would just call it common sense. But the new hot term, the acceptable term today is population health. Right? Now, if this idea isn't new, right, we've been saying for a long time, you know, Benjamin Franklin knew about this, or as he said when he was in France. It's actually pretty funny if you think about it. Right. Well, why are we talking about population health now? Why suddenly in 2013, 2014 is population health all the rage when we talk about healthcare? This isn't anything new. Why are we talking about it now? And there's really two answers to that question. There's an easy answer and a more complicated answer. How many of you are undergrads? And how many of you are grad students? All right, I'll give you the more complicated answer too. Okay, that was a joke also. All right, so why are we talking about population health now? Well, the easy answer is we're talking about it because it's part of the Affordable Care Act. All right? The Affordable Care Act specifically encourages providers to begin taking responsibility for the overall health of the populations they serve. All right? The Affordable Care Act, also known as Obamacare, has a number of provisions that make population health important. It requires tax-exempt hospitals to do community health needs assessment. It expands coverage for a wide range of preventive services. It increases accountability for care outside the four walls, encourages partnerships, and has a sustained national investment. So, if for no other reason, if you believe, as most people do, that the Affordable Care Act will stay around in some capacity for some years to come, this will be an inevitable part of the world that you're going to enter. Whatever role you play in healthcare, you're going to be a part of delivering care under the Affordable Care Act. But there's a more important reason why we're talking about population health now, and that is because even if there were no healthcare reform, all right, even if there was no Affordable Care Act, even if it was repealed in total, there are certain aspects of our healthcare system that simply require us to rethink how we promote and protect the health of the American public. All right? There are some aspects of our healthcare system that simply aren't sustainable if we don't rethink the way we provide health care. All right. And I'm not going to go into a great deal of detail. I mean, all of you know that in the United States we pay more for health care per capita than any other of the developed countries in the world, pretty much 50% more per person than any other country in the world. If you look at the percent of GDP, again, pretty much 50% or more than any other country in the world. All right. You all know that. It's 17% of our gross domestic product goes to health care. That's not sustainable. It's especially not sustainable if you look at change over time. All right? So this is all those same countries from 1980 to 2010. And what you can see is back in 1980, we were all pretty tightly packed. From 1980 on, the U.S. has gotten more and more expensive. And by a few years ago, the gap was wider and wider. And if you think about it, that's simply not sustainable. Okay? Now, before you jump ahead, some folks will say, well, wait a minute. That's not necessarily a bad thing. If we're getting more health care or better health care, then yeah, we might be paying more than other countries, right? So what are we getting for all that money? Are we getting more health care? And the answer is no. If you look at the same countries, the number of physician visits per year per person, the U.S. actually gets the second least number of health care visits per person for that great amount of spending. And if you think about it, these all countries all have some form of universal access to affordable health care except us. And in the U.S., there's something like 50 million Americans who don't have health insurance. Now, I could walk you through why that matters. You know, some people say, oh, so those are just young, healthy people who don't ever use health care. No, we've got good data to document that people who don't have health insurance don't use health care, particularly don't use preventive services. So the answer is no, we're not getting more health care. So then the question is, well, maybe we're getting better health outcomes. I mean, most of us would be willing to invest in better health outcomes. We'd pay a little bit more than other countries, thinking that we're going to get better health outcomes than they do. Well, how do we measure health outcomes? There's 1,000 different ways. The most basic way you measure health outcomes for a country is life expectancy, right? Life expectancy is how long a baby born today is projected to live. Life expectancy. If you think about it, it's the most basic, fundamental measure of health, right? Everything that goes into your life is reflected in life expectancy. How old is mom when she gets pregnant? Does mom use tobacco, alcohol, or other addictive substances during pregnancy? Is that baby born in a safe environment? Does that child have enough food and clean water? Does he grow up in a country free from war and famine and civil strife? Can they get an education? Can they get a job? If they get ill or injured, can they get access to health care? Do they have a meaningful role in society? All of those factors times 310 million make up life expectancy in the United States, right? And if we went out on the streets of Johnson City and we asked the man on the street to tell us two things about life expectancy in the United States, he'd likely tell us these two things. One, he'd tell us life expectancy in the U.S. is probably the longest it's ever been. And the man on the street would be right. In 2012, life expectancy in the U.S. is 78 and a half years. A baby born today in the United States is projected to live 78 and a half years. What's really remarkable is 100 years ago, at the beginning of the 20th century, life expectancy was in the 40s. In the course of a single century, in our country, we added 3 decades of life expectancy to a baby born in the United States. And that's pretty consistent with what most people think about our healthcare system in the U.S., right? And the second thing the man on the street's likely to tell us is that life expectancy in the U.S. is probably the longest in the world. He knows that we spend 50% more on health care than anyone else in the world. He knows that we have a health care infrastructure unlike that anywhere in the world. He knows we have a system for educating health professionals that's arguably the best in the world. He knows that people come to the U.S. for health care, right? So he assumes that life expectancy in the United States is the longest in the world. But here the man on the street is wrong. In 2012, the United States ranks behind all of those countries and ranks 33rd or so in the world. Almost 36 countries where a baby born today is projected to live a longer life than in the United States. 36 countries that do better at this basic fundamental measure of health than does the United States. And if you look at all 50 states for life expectancy, from Hawaii at the longest to Mississippi at the shortest, there's Tennessee way down there at 44th. The 7th least healthy state in the nation is the state that you're in right now. If we were to compare Tennessee to other countries, from United Kingdom ranked 25th down to St. Vincent at 75th, we'd fall somewhere around here: Uruguay, Saudi Arabia, United Arab Emirates, Argentina, Czech Republic, and so on, okay? So here we are at the state that ranks 44th and the nation that ranks 33rd in the world for this basic fundamental measure of health. And I suspect most of you are asking two pretty obvious questions at this point, right? The first question is why? Why do we have health statistics in our state of Tennessee and in our country that are so much worse than we could achieve? And we know we could achieve it, right? If other countries have a longer life expectancy, that means there's nothing inherently inevitable that we die young, right? And if Tennessee is ranked 44th, that means there's 43 states that have done better at this measure than we have. So the first question is why, and the second question is what, which is what can we do about it, okay? And that's really the idea behind population health. If you want to understand why we're doing worse in the US, why we're doing worse in Tennessee, and what we can do about it, you have to understand the factors that are causing us to die young. This is an article from the New England Journal of Medicine, 2007. It asked a really simple question, which is, okay, what are the factors that cause us to die young, premature death, early death in the United States? Now, not the diagnoses, not the things that kill us, right? The top 5 causes of death are heart disease, cancer, stroke, chronic obstructive pulmonary disease, and accidents. 2/3 of you in this room will die of one of those 5 causes: heart disease, cancer, stroke, chronic obstructive pulmonary disease, or accidents, barring unforeseen, asteroid strikes or alien abductions or the zombie apocalypse or something. But what are the factors that lead you to those 5 causes of death? What are the factors that cause Americans to have heart disease, cancer, stroke, chronic obstructive pulmonary disease, and accidents? Well, according to this article in the New England Journal, 1/3 of it's due to genetics, what you inherit from your family. Not much you can do about that. 5% due to environmental exposures. 15% of these deaths due to social circumstance. And that leaves 2 wedges in the pie, a small one and a big one. And people are often surprised to learn that the small wedge is healthcare. What this is saying is that if all Americans had access to the very best healthcare, which we do not, we would reduce our early death rate by about 1/10. That's really important, right? If we could reduce our early death rate by 1/10, we should do it. And I strongly believe that all Americans should have access to affordable healthcare. That's not a political statement. How you pay for it, how you get there, that's politics. When I say all Americans should have access to affordable health care, I'm saying that what I want for myself, what I want for my family, what I want for you, I should want for everyone, okay? But what's this big wedge in the pie? What's this thing that's causing almost half of our early death in the United States? 40% of our deaths are due to behaviors, the things that we're doing, okay? Now, there's a good news, bad news story in this. The good news is behaviors can change. The bad news is we obviously haven't changed the behaviors, or we wouldn't still be dying from them, okay? So let's take a look. This is the United States as a whole. Let's ask the question, do these things apply to us in Tennessee? And which of these are causing us to be the 44th ranked state and the 33rd ranked country in the world? Is it genetics? Maybe there's something about us in Tennessee that we're just born with poor protoplasm. And those of you that chose to move here, sorry. I can't disprove that except to show you some interesting information. Some of you have heard of this woman, right? Bess Brown Cooper. Bess was born in Sullivan County in 1896. She graduated from ETSU in 1916. She was, for a number of years, our oldest living alumna. And we know that because for 2 years, from January 2011 to December 2012, she was the world's oldest living person. Not the oldest person from Tennessee, not the oldest graduate from ETSU, the oldest person in the world, and one of only 8 people ever known to reach the age of 116. And this doesn't prove anything at all, except to suggest there's probably nothing wrong with our protoplasm, right? If this area can produce the world's oldest person, it's probably not the reason that we're dying young, all right? Well, what about healthcare? Maybe healthcare in Tennessee is just so bad, so few people have access to healthcare that that's what's causing us to die young. Well, if you look at things like how many docs we have per capita, we're actually 18th. We're in the top half for the nation. If you look at the number of percent of people that lack health insurance, we're in 22nd, top half. Both could be better, but that hardly explains why we're the 44th state in the nation. All right. So let's look down here at these behaviors. Obviously, that's the thing everyone thinks of, right? And according to the Centers for Disease Control, what's the number one behavior that causes Americans to die young? Smoking, right. Nicotine addiction accounts for about 1 in 6 deaths in the United States. Second, what do you think?
Alcohol.
Alcohol's third. Someone said it. Obesity, yeah. Factors related to that. These two together account for about a third of our premature death. And then the numbers drop off pretty quickly. Alcohol is third, 3.5%. Infectious diseases, 100 years ago, these were by far the leading cause of death, 3%. Toxic agents, secondhand smoke, environmental pollutants, 2%. Motor vehicles, self-explanatory. Firearms, somewhat uniquely American and self-explanatory. Sexual behaviors, it leads to diseases like AIDS and illicit drug use. These are the things the Centers for Disease Control says we're dying from. Okay? Now you all as public health students look at this list and two things should jump out at you. First, these problems can be solved, right? Look at this list. If we had time, or when you go back to class, you could spend an hour and come up with 5 or 10 evidence-based interventions that you know would work for every single item up there. There's nothing up there that you don't know how to impact. Think about it. Look up there. Is there anything up there that can't be solved? But there's a more important lesson that you as public health students should see in this list that maybe medical students and nursing students won't see. And that is that these problems are more easily prevented than cured. Go back to this list again and ask yourself, what are the items up there that you can go to the doctor to be cured of? The only one arguably is infectious diseases, right? You can get an antibiotic. Everything else requires prevention. Everything else requires a population approach. Everything else requires public health. Right? These are the reasons we're dying in America. And these are the reasons we're dying in the state that ranks 44th in the nation, ranks 33rd in the world. So let's ask the question, how does Tennessee do in each of these areas? So let's look at tobacco. We just celebrated the 50th anniversary of the Surgeon General's report on tobacco. When it started, smoking was way back here, slightly close to 60% of Americans. It's been slowly decreasing. And the good news is it's under 20% now. The bad news is 50 years after we figured out that tobacco kills, we still have a fifth of Americans smoking. Tennessee has been coming down as well, a little sporadically, but ranking about 5 years behind the rest of the country in terms of timeline. If you look at all 50 states, from Utah at the top, there's Tennessee, the 4th highest smoking rate in the nation, with about a quarter of our adults reporting that they're addicted, that they use tobacco products. Okay, so clearly if we're looking at how we improve health in Tennessee, it's not just getting better health care. It's making sure that we figure out how we get back up the channel so that we can prevent kids from becoming smokers and we can help current smokers quit. All right, what about obesity? Well, you all know there's an obesity epidemic in the United States, right? I think most of you have seen this map. It's the United States. All right, 1986, U.S. The states that are in white have no data. The light blue states, including Tennessee, have less than 10% obesity, and these states are 10 to 15%. In 1986, no state with over 15% obesity. I put the chart into motion, 1987. We get more and more data from more states. Then in 1991, for the first time, we have states that are 15 to 20%. Tennessee joins that group in 1993, drops out in 1994, comes back to stay in 1995. Then in 1997, for the first time, we have states that are 20 to 25%. Tennessee joins that group in 1999. Then in 2001, Mississippi becomes the first state with 25 to 30%. Tennessee joins that group in 2004. Then in 2005, we have the first states with over 30% obesity. Tennessee joins that group in 2007. Watch Colorado, the last state with under 20%. By 2010. So between 1986 and 2010, you've just seen a map of an evolving epidemic disease in our country. Remember, there was not a single state over 15%. Now there's not a single state under 20%. Now, the CDC changed the way they collect the data in 2011. They changed the colors. It drives me crazy. I wrote them a letter. They ignored me. Didn't realize my kids worked at the CDC. But you see, briefly in 2011, Tennessee dropped below 30%. And then by 2012, we came back again. And so you've seen, again, this evolving national epidemic. It won't surprise you to look at all 50 states from top to bottom. And Tennessee has a rate almost a third rate of obesity in our country. So if we look at this list, I'm not going to go down the rest of the list. Clearly, one of the answers to the problem of why Tennessee ranks 44th is that we're engaged in these behaviors at a higher rate than the rest of the country. All right? And about 10 years ago, that's where this lecture would have stopped. I would have said, guys, we've got to go out and change people's behavior. But now we know more about this aspect here, this so-called social circumstance. This is really the cutting edge of public health. Understand the impact that social conditions have on people's health. All right? So we used to think of health this way. It's basically what you inherit. It's your genetics. And maybe a little bit of access to health care. You know, whatever you get, if you can get to the doctor, be treated, that's fine. Then we've come to realize that there's these behaviors that really mitigate our health. And now we realize there are all of these outside factors that we call the social determinants of health that impact on us. And if you think about it, you know, if you live in a dangerous community, a high crime rate, it impacts your health. If you have a job like lumber or something that, you know, is a risky job, it impacts your health. All of those will make sense to you. But how incredibly strong these relationships are is really the message that people haven't been getting. So I just want to talk about two of them. The first is income. You know, if you think of poverty and health, right, it's sort of consistent with our worldview. You think of the least healthy countries in the world, the poorest countries in the world, you pretty much have the same countries, right? But what people don't realize is that this relationship exists in the United States, all right? I don't know how many of you saw the Dean's note earlier this week. In fact, it was yesterday. This is what your chance of dying is before the age of 65 based on your income in the United States, okay? So here's wealthy Americans with an income over 100,000, each progressive 50 to 99, 40 to 49, and then under 10,000, okay? If you hold the relative risk for this group as 1, poor Americans are 3 times more likely to die before the age of 65 as rich Americans. Now think about that for a second. In our country, with all the resources, all the wealth, all the capability we have, a poor American is 3 times more likely to die before the age of 65 as a rich American. And it's this remarkable linear relationship. It's not that it suddenly falls off. It's this direct, straight line relationship. Now this becomes really important for us in Tennessee because if you look at the percent of children that live in poverty in our state, 1/4 of our kids live in poverty, and we rank the 9th poorest state in the nation. So clearly, if poverty is associated with poor health, and you want to improve health in Tennessee, we've got to focus on improving economic opportunity. Unfortunately, there are data that suggest that in our country, the gap between rich and poor is actually widening and not narrowing. And let me show you these data. This is from the Census Bureau, okay? And what this does, it divides Americans into quintiles, into fifths. All right? So the poorest fifth of Americans, the richest fifth of Americans. This is how much money they make. Each bar is a decade. 1971, 1981, 1991, 2001, 2011. Does that make sense to you? The average income for the poorest fifth. So this is not the poorest of the poor. This is the poorest fifth. And this is not the richest of the rich. It's the richest fifth. All right? So in 1971, the poorest fifth of Americans made $10,360. By 2011, that went up to $11,239. So in 40 years, the poorest fifth increased their income by 8.5%. At the same time, the richest fifth of Americans increased their income by 51% in actual buying power. These are constant dollars over time. So the ratio went from 11.4 to 1 to 16 to 1. Now remember I said that's not even the richest Americans, that's the top fifth. So what if we look at the top 5%, that's the 1 in 20? Even that's not the richest, because remember in a room like this, 3 of you are in the top 20% for income. All right? The ratio has gone from 8.5%, see an 81% increase. So I don't put this up to make an economic point, because I'm not an economist. Right? And I don't put this up to make a political point. I put it up to make an important public health point. Because what this means is that the gap between rich and poor is widening, and those parts of the country like Tennessee that have a disproportionate number of poor people may see a widening gap over time and not a narrowing gap. And if you really want to improve health of people, it means you've got to work with the economic development community to bring in good jobs and get economic opportunity for people so that we can actually increase that and reverse it. Because if we don't, we may well see a widening gap over time. The only other one I want to tell you about is education, because some of you have an investment in it. All right, so this is an interesting bar chart. Life expectancy at age 25. How many more years are you going to live by the time you're 25 based on your education? So this bar here is for men. These bars are for women. If a man is a high school dropout, by age 25, you can be expected to live about 47 more years. A college graduate at the time, 54. What's remarkable about this is how incredibly robust this relationship is. Right? 5 years for women, 6 years for men. If you have friends that are still in high school, right, and they're thinking of dropping out, you can tell them that on average, the difference between a college graduate and a high school dropout is $1.1 million in lifetime income and 5 to 7 years of life expectancy on average. That's a pretty remarkable statistic. It's important to us in Tennessee because if you look at the percent of residents with a bachelor's degree or more, there we are again with about a quarter compared to the high of almost 40%. Here again, there are some data that suggest that the gap is widening and not narrowing. All right, and let me show you this. This is a little bit of a complicated chart. But what it does is it asks a really simple question, which is, okay, if you take a bunch of high school sophomores, how many of them will have a college degree in 10 years? So how many people will complete a 7-year journey in 10 years? 3 years to finish high school, 4 years to finish college. For some of you, a bit more. All right, what's really amazing about this is if their parents are professionals or doctorally prepared, 3/4 of those kids will have a college degree in 10 years. If their parents are high school dropouts, only 6%. 12 times difference between the likelihood of getting a college degree for a sophomore based on their parents' education. What that means is the parts of the country with lower rates of educational achievement might see a widening gap and not a narrowing gap over time. So if you really care about improving health of people, you've got to work with the education community to make sure we keep kids in school, give them good opportunities, get them into and through college. All right? So we look at this list, and it helps us understand what we need to do to improve health in Tennessee, to improve health in the United States. We have to, of course, improve health in Tennessee, improve health in the United States, or more generally improve population health. We have to do 3 things, right? We have to make sure people have access to affordable health care, including preventive services. We have to help change behavior. Now these 2 things are things that we're pretty comfortable talking about. We talk about these things in public health all the time. But the third part of the triangle are these social determinants. If you really want to improve health, you've got to focus on all 3. All right? And you've got to understand something really important. And that is, none of these can be successful without the other 2. You ask a business leader what they need to bring a good job to Tennessee, and they will tell you they need a healthy, educated, drug-free workforce. You ask a school superintendent what they need to get better schools, they need parents with jobs and a tax base because that's how it pays for schools. And they need kids and parents that have the behavior and the attributes to bring those kids to school. They need teachers that can show up. You ask a healthcare provider what they need. They want people to have good behavior, right? Quit smoking, get exercise, and so on. And they also need jobs so that they can get to pay for their health care and their medication. Okay, these things are all interrelated. All right. So if you put it into words, what do we have to do to improve population health? We need to work together to assure access to affordable health care. And again, I'm not talking about necessarily the Affordable Care Act. I'm not saying that that is or isn't the right approach to take. I'm just saying that we need to make sure people have access to this affordable health care, including preventive services. We need to work together to encourage healthier behaviors, and we need to work together to enhance economic opportunity and improve educational achievement. And what these all have in common, of course, is we need to work together. These are not problems that Washington, D.C. or Nashville can solve on their own. These are not problems for Republicans or Democrats or libertarians or anarchists to solve on their own. These are not problems for business leaders, educators, faith community leaders, or physicians to solve on their own. These require us to work together. Your lives as healthcare professionals are going to be inexorably intertwined with this concept, that you'll be doing all three of these things. Now, when you see that, when I talk about this to health professional students, they often say, well, there's two objections, right? One is, that's not really what I'm studying, right? I'm actually going to be a hospital administrator or a nursing home administrator. I'm going to be a health educator. I'm going to be an epidemiologist. I'm going to be a dean of public health. Whatever you do in healthcare in the next couple of years, couple of decades, you will inexorably be doing this. And even if it wasn't the law of the land, as a healthcare professional, you've made a commitment to improving the health of the people that you serve. And that's what requires you to reach beyond the hospital, reach beyond the nursing home, beyond the clinical trial. We all have obligations as health professionals to address this issue. So then the second concern that you're going to raise, reasonably, is that trying to change the health of the people of Tennessee is too big a challenge, right? It's overwhelming. There's really nothing. I mean, what are you going to do? 44th state and the 33rd nation in the world. Well, you remember I showed you this picture earlier. I want to introduce you to this guy here. He's a physician born in the 1850s, about 9 counties north of here. Went to Virginia Military Institute as an undergraduate, went to University of Virginia, got his medical degree, went out and fought in the Indian Wars, and then came back and became the health officer, the city health officer in Charlottesville, Virginia. And for those of you considering a career in public health, let that be fair warning. Right. Now, I'm interested in this guy, because he was the city health officer about 100 years ago, just about exactly a century ago. And what makes me interested in him is I have a book in my office called the Virginia Health Bulletin from 1908 and 1909. And it has a picture of the leading causes of death in Virginia at the time. Tuberculosis, remember I mentioned infectious diseases was the leading cause of death 100 years ago. Cancer, whooping cough, typhoid, influenza, diphtheria, scarlet fever. Right, those are the leading causes of death. Now, why is that interesting? Because 100 years ago, there were no antibiotics. There were only 2 vaccines in the whole world, and they weren't for any of those diseases. There were no magic bullets. Yet this guy and a bunch of other sanitarians, nurses, doctors, public health professionals did something really remarkable. They increased life expectancy by 30 years. Go back to this chart and look, the vast majority of that life expectancy was gathered in the first half of the last century, before most of our modern medical advances even happened. All right? Now, this guy is not famous, right? His name isn't on anything. There's no buildings named for him. But I'm interested in him because he's my great-grandfather, right? And I wonder, what would it be like to work at a time where the challenges seem to be too great? All right? Well, there's another picture in the Virginia Health Bulletin from 100 years ago that I think says more about population health than any lecture, any textbook that I own. Okay? I'm going to show you this picture. Now, this is all you remember about public health. You'll be well prepared for your careers, more or less. You still have to take the comprehensive exam. Okay, so here's this picture. On one side are the leading causes of death of the day, diphtheria, scarlet fever, measles. On the other side are the rather oddly dressed children of the time. They knew 100 years ago that they could change the lives of the children that they serve. Public education, careful physicians, efficient health officers. They knew 100 years ago. They didn't throw up their hands and say there's no magic bullet. They said, how high is the wall in your town? Well, today the leading causes of death have changed, right? Heart disease, cancer, stroke, chronic obstructive pulmonary disease. There's still no magic bullets, if you think about it. But we can be just as optimistic that we can make a difference in the health of the population by building a wall. Maybe today we'll say that wall is prevention. You know, people engage in better behaviors. Healthcare, access to affordable healthcare, access to education, economic development. We can be just as optimistic that we can improve population health by building this wall, by working together. This is going to happen. It's going to affect everywhere in the country, every state in the nation, but probably nowhere more than right here in Tennessee. All right? Now, I've introduced you to my great-grandfather. That's my son, Kevin. That's my son, Gregory, a graduate of this college, now over at the Quillen College of Medicine. That's my daughter, Kathleen, now a student in this college, though I don't see her here today. That's my same son, Kevin. That's my wife. That's me. I end with this slide to remind me to tell you that nothing that I've said has anything to do with politics. It has very little to do with healthcare. It really has to do with whether or not we, as leaders of our community, will make the kinds of decisions that we need to make to hand our children a state that is as healthy as it is beautiful. I like to define public health as evidence-based altruism. You're going to go out with a commitment to improve the health of the people that you serve. I challenge you to use the evidence that you find, regardless of how it's presented, and really work with others to build a wall that will make our state and our nation healthier. I'm happy to answer any questions. If they're easy, I'll be happy to answer them. If they're difficult, I'll let Dr. Corey answer them.
Okay, well, let's, I guess, turn the lights on.
Okay.
Okay, now, you're away. Questions? Comments? We're good on time, but the light is good today, time.
Okay, remember, if you don't ask me a question, I've got a question I'm going to ask you. So you might as well. All right, here's my question for you. Be honest. What did I say that you disagree with? Because every one of you disagrees with at least something that I said. No, seriously. I mean, this is a subset of all the statistics that exist, right? Yeah.
I thought it was very powerful, and I teared up and almost cried a couple of times.
Oh, okay. Good. Well, it means you probably chose the right field, right?
Yeah.
Okay.
And the question or the acknowledgement is that we work together. We work together. That is the home statement. Now, for the time I've been studying the codes and been reading some of the history, you find out that we got a serious problem when it comes to converting healthcare to business.
Mm-hmm.
Out of the history that one reads about healthcare, it started very little with people having compassion, and then it always started to convert people wanting to make so much and trying to consolidate themselves and putting barricade or barrier for other people to enter, thereby making it something that they will have a decision to make. Now you have the insurance company and the care management groups that decide what will get what. Now, under those kind of conditions,
How do we convince?
how can we work together when people who have such an economic interest in back them?
Well, and that's a good question. The question is, how do we work together when there are different economic interests? I think the key is we've got to learn to speak each other's language. There's a language that economic development speaks. There's a language that that education speaks. And in public health, we've sort of spoken our own language. If I were talking to businesses, what I would say is, look at the large self-insured businesses. What have they learned? They've learned that they get a 2 to 3 to 1 return on investment when they invest in health. When they invest in employee health and wellness, 2 to 3 to 1 return on investment. It's a winner for them. And the other thing is, the bottom line is, even people who lack health insurance end up getting health care. They get it through the emergency room. It's really expensive. We end up paying for it anyway. Big corporations pay huge amounts in retiree health benefits. It would seem to me, if I was a big company, I would want universal access to affordable health care. It would seem to be in my economic best interest. So we have to reframe the argument in a way that makes sense to folks. Some people want to hear poverty reduction as a term. Others want to hear economic development as a term. It's not really that different. We want people to have good, meaningful jobs. It doesn't matter what you call it. So I think part of what we have to do is learn to speak other languages. We need to be able to present data in a way that's not threatening. I don't want to stand up here and say, you is a bad person. We all benefit. Everyone benefits if we have a healthy, educated, drug-free workforce. That's just everyone does. It's a winning situation, and we can depoliticize it. We can let the debate be about how we pay for health care reform if we want, but we shouldn't argue about the facts. I know it's a little optimistic, yeah.
You're talking about how the cost of healthcare in America is so much more than in other countries. Then why are all of the people who previously had insurance having to pay more now?
Not all are. What's happening is there's a minimum package of insurance that may cost folks more than what they were getting before, but
It seems to be making things cheaper if people are having to pay more.
well, the healthcare reform is in the short term not going to save a great deal of money. The initial estimates were that by 10 years out it would start saving money in the health system. I didn't show you, there's a slide that breaks down how much we spend in healthcare. We spend the second most in out-of-pocket expenses of any country, any developed country. We spend the second most in public spending, and we spend by far the most in private spending. So the idea is to at least consolidate these costs, and we can start to control them a little better. But healthcare costs wasn't the primary driving force of the Affordable Care Act. It was to get those 50 million people covered. I don't know, Colin, do you agree with that, or?
I do.
Okay. Yeah.
How did you find out what was killing the children?
We never did. Don't know. I always figured that one day it would come to me, and then I realized 5 years ago that what came to me was this bigger lesson that we really can't provide our patients the best possible care unless we can get back up to the other campus.
So the biggest thing I was thinking of is behavioral, and then we didn't focus on. We looked at income and other things. The only, in my limited experience, the only thing that I've ever seen really change behavioral is a change of faith. And how do you change 40% of...
Yeah. The question is, how do you change behavior? And the answer is, we actually have some pretty good evidence. We know, for example, the best way to reduce youth smoking is to increase the price. We've had pretty good data from California and other places. Obesity, we don't have as good. There's 27 or 28 things the CDC has found that make a difference for communities. I think probably the biggest change, again, without any evidence, my own personal opinion, is what we really need to do is start teaching health more holistically in the K through 12 system, so kids know more about themselves and can make more intelligent choices. But each step on there is a difference. We've seen a reduction in drunk driving because of a social movement. We've seen reduction in smoking because of the cost, and we've seen reduction in infectious diseases because of immunization campaigns. Each item is a little different. Yeah.
As people are talking about the issue of behavior, I would like to point out the fact that regardless of what is wrong with the U.S. health system, is one of the best in controlling tobacco use. We were able to cut out tobacco use from about 50% 50 years ago to less than 20%. So it means what we did 50 years ago, well, what we have to do now is to do more of it.
Yeah.
So that's I just want to point out.
Yeah, no, the point is that we did make a huge difference. We had a national movement. Tobacco is an interesting case study. Dr. Mahmoudou is one of the world's experts in tobacco policy, so I won't say much about it, other than to say, you've got a balance between the factors that are trying to promote the increased use of a product and public health factors that are trying to decrease its use. Yeah.
I have a question. May not be directly related to what you said, but we are trying to promote or stop people from smoking. Now, in the last few days, I've been seeing all over the place electronic cigarettes. So how does that help us?
What was the e-cigarette, yeah. It's an interesting question. From a public health standpoint, the data are still not definitive. The early data suggest that it's, for someone who's addicted to nicotine, it's probably a safer alternative than taking in smoked tobacco. But there are health risks from nicotine in and of itself. It has cardiotoxicity and so on. The studies have not been done, at least to my knowledge, of using it as a pathway off of nicotine. As with patches and the gums and the sprays and so on. The question is whether it's going to, it could have longer-term social impacts. It could reestablish nicotine addiction as a social norm. It could, in fact, lead people back to smoked tobacco. There's a lot of unanswered questions about it. I wouldn't, for someone who is not currently addicted to nicotine products, I wouldn't suggest it.
Let's say we become health leaders in small rural counties, or poor governmental infrastructure, limited resources, limited access to health care, high dropout rates. What has been your experience has been the best way to make the quickest impact on somebody? The chances of recruiting economics in are going to be low.
Yeah. That's actually a really interesting question. The question is, so what can you do? What's sort of the quickest impact in a high-risk community? I used to say, get people to quit smoking. That's the leading preventable cause of death. Then I started thinking more about the social determinants and started saying, no, we really need to get people that get an education, and at least then they have the opportunity for economic growth. There's a whole other theory put forward by Michael Marmot, who's sort of the world's expert on this, about status syndrome. And it's very much how people feel about themselves, how they see themselves in society makes a big difference in their health status. And so in some ways, what I think we need to start doing is start reaching our kids and making them feel pretty good, making them feel like they're empowered to make these life decisions. I know that sounds kind of soft and squishy, but I think giving kids that sense of confidence, helping them make good choices about their behaviors, probably is the best investment we can make today. So here's just a thought process. I once asked Hal Knight, the dean of the Clemmer College of Education, what's the greatest predictor of high school graduation? Because I want to see more kids graduate. He said it's third grade reading level. What's the predictor of third grade reading level? Well, the parents read to their kids at home. This stuff has a long lead time. So if we really want to improve health in the community, we need to take a 20, 30-year view. My friend Renslow Shearer used to say the best time to plant a tree is 20 years ago, and the second best time is today. So let's start planting this tree, making kids healthier, let's take a long view, make kids feel good about themselves, make them realize that they should make good decisions for their own health, and then hopefully everything else will follow from that. Karen?
I was going back to the slides where you're showing the different states and the rankings. And we're always within that same area. I wouldn't think that the factors that cause us to be there are that different in many states. So why is it that we can't seem to improve?
A lot of the predictors emanate around factors associated with poverty. The greater rates of poverty in a state pretty much predict where they're going to be. We know that poor Americans are more likely to smoke, less likely to exercise, more likely to live sedentary lifestyles. We saw the chart that people that are less educated, the children of less educated, it's all a vicious cycle. Now it can change, okay? This is an important thing. In 2005, Tennessee ranked 49th in the nation for high school completion. Last year, I believe they ranked 24th. Huge change. These things can change. We just got to have a concerted effort. Leadership from the governor. Tennessee is a tobacco-producing state, and yet it's been a smoke-free state for a number of years. I mean, we can make these kind of decisions.
I guess, really, to what extent the fact that, we're making those changes, but if I hear, Karen, she's saying we're still roughly in the same spot nationwide. it makes me think, to what extent are the other states also making changes and just staying ahead of us?
I guess the difference is not very much.
Right. Rankings are misleading in a sense in that they don't tell you how far apart states are often. And sometimes we'll see our rate get better and our ranking get worse, or our rate gets worse, our ranking gets better. But they're just general descriptors. I think it's sort of like this concept of teaching to the test. If you focus on what's going to get measured and make a difference, we know we can change that. We can change school completion rates. Can we improve economic opportunity slowly over time? Because we're not going to bring the businesses in until they know there's an educated workforce, a healthy, educated, drug-free workforce. So it takes time, but it can change. And you hate to see yourself being competitive with other states. You may hate it, I don't. So I don't have any problem at all trying to be healthier. Yeah.
Last question.
In regards to teaching kids healthy behaviors and choices, I know Tennessee currently ranks the top 2 reportable diseases are gonorrhea and chlamydia, and in like 2 years ago, politicians have passed a law where they ban teaching sex ed in schools and high schools and so forth, and teaching abstinence only, even though there's evidence-based research that shows that teaching kids earlier on healthy choices and healthy options, to protect themselves and stuff, actually decreases them and decreases teen pregnancy and stuff. How would you say, what's the best way to go about and working in a situation when, cultural beliefs and their stigmatized choices that are being made? How would you go about working?
Yeah, no, I think that's a good question, and I think there's sort of 2 strategies. One is talk about health education in a general sense. Health education really shouldn't be just sex and drugs, which is what we tend to talk about. Health education should be, this is how your body works, this is what does what to your body, good, bad, indifferent. It's politically neutral. So first of all, you lead with that. The second thing, and this is something that I learned some decades ago, every public health problem is a sequence. All right. So let's take the one you mentioned, sexual activity. Okay, you've got a young girl who's not sexually active. Then she becomes sexually active. Then she might develop a sexually transmitted disease. She might get pregnant. If she gets pregnant, the child might get she might get prenatal care, might not. The child might be born in a safe environment, might not. Each step in that process, there are very reasonable interventions that should be made. And if you have folks in your community that really believe that abstinence education is the right way to go, have them focus here in the sequence. And have them understand that that doesn't make it inappropriate for you to work on making sure that a pregnant teen gets prenatal care, or that a sexually active couple is using some protection against pregnancy and/or sexually transmitted diseases. It's you don't dismiss it. It has a place. It has a role. And if you are inclusive in your planning, you can get those folks to focus on that part where they're comfortable. Most folks aren't going to say if there's a girl or boy, anyone who gets a sexually transmitted disease shouldn't be treated because they shouldn't have been sexually active to begin with. So let's get everyone focused where they're most comfortable and where they can be most effective. If we work together, then we've built a wall instead of 2 opposing camps.
Okay, great. Thank you very much.